Meow. Hi everybody, Huples cat. March 22nd. Just want to do a bit of a quick video and do some updates. Hopefully it won't be too long. I always say quick videos and they're too long. So we're off today and Kitty's back to work tomorrow for one night, and then we're both on Thursday. So I'm actually off for a period of time. So I've been doing a few chores around the house, and we took the dogs for a walk today. And we kept our social distance from everybody. There's surprisingly few people out and about in the Newmarket GTA area actually taking advantage of the sunlight, even though it is pretty cold. And I think people are starting to get a realization up here that this is more of a bigger deal than not. But the main purpose of this is to update what's been going on in my hospital. I'm going to put up a few slides. They're not for reproduction and nor are they sanctioned by the hospital, just to show you what it's looking like in one hospital on the ground in terms of how many people we think have or might have COVID-19, to the point where we're serious enough to test them. We're not testing mild symptoms, we're not testing no symptoms, we just don't have the testing capability. Testing is taking about 48 to 36 hours to do a turnaround. It has been going 5 days for some people. The whole point of testing is to get a handle on what the infection's doing in the local area, and also to institute precautions at work. Up to a certain point we're going to do precautions anyway without testing, but we're limited, and I want to talk about that. So the hospital, my hospital, has banned all visiting for 24 hours a day. There's no visiting whatsoever at all. There are a few exceptions. Neonatal ICU and labour and delivery, which is actually in a separate wing of the hospital, they're allowed to have very limited visiting, but there is still visiting going up on there 24/7, but it's one person at a time and occasionally two parents. We're very being strict on that. Been a few issues, people trying to figure out, people come in and then they leave and then they're not allowed back in again, and they're trying to get back in with a car seat to put the new baby in to take them home. So there's a few mechanical things going on. Some of the labour and delivery nurses are unhappy that they have visitors, all of that sort of thing. People are starting to get quite concerned at work in areas that they didn't think they were going to be exposed, and now realising that the exposure is community and everybody's at risk. So I think that was a bit of a shock for some of them. The other thing we did was quite dramatic this week. We stopped all list case surgery. Well, we didn't, because we're a strange hospital. There are some list case going ahead if the doctors think they are needed. But by and large it's been stopped. So this plunged our occupancy. Our occupancy for our hospital beds is usually about 98 to 120%, because we use stretchers a lot and there's a lot of admitted patients, generally speaking, emerge. That's plunged down into the 70s over the few days that we've stopped surgery. Also, people aren't coming to our hospital. Our hospital was well known in SARS in 2003 as one of the very few hospitals that managed to infect almost all of their ICU team by bad practice, and that was well known. Although the government tried to blame a nurse who was male who had a goatee, who had absolutely nothing to do with the spread, it was bad practice, illegal practice actually. People in the community are avoiding our hospital. Also, people who would go to the emerge, generally speaking, for what we might call trivial reasons, but they wouldn't, and they need healthcare, and it's hard to get healthcare without a family doctor. They tend not to be coming anymore. So emerge volumes are way down. The acuity is not up as much yet. We're doing screening at every door. If we have screeners on nights, oftentimes there's no screeners because we don't have people to do it. They are not doing temperature screening because it's pointless, it doesn't work, and it's false negatives most of the time. What we're doing is just asking for ID badges, so members of the public aren't coming in to try and steal supplies, and they're also legitimate visitors, not people just decide to visit their auntie because, well, I'll go and visit my auntie. They're not being allowed in. 24 hours solidly, no visiting. If somebody's about to die within the next 48 hours and not critically ill, but about to die for sure, then we'll let one person in at the moment. The other things that have been coming up is when we've had PUIs die, what do we do with the body? Can it go to the general morgue? Are there any special precautions we need doing? So that part of it was kind of overlooked, so now they're looking at that. The other thing we did, which I said was dramatic, was we decided to take, we have two surgical step-down units. One's trauma ICU heads and one's surgical, medical. So the medical unit was shut. That's only 8 beds. And those poor nurses were informed that from now on they're the COVID ICU for both level 2 and level 3. Level 3 is patients who've got ventilation, and level 2 are patients who need half a nurse all the time that aren't ventilated yet, and might be. So they have suddenly found themselves to be the COVID ICU. They're pretty much full. They got full within about 12 hours from PUI admissions from Emerge. We didn't transfer in from the rest of the hospital, but just from the Emerge volume, they filled up almost immediately. A lot of pressure on them. They came up with normalcy bias. We're not using agency nurses because they're not trained in PPE. We don't have the staff. They're now using agency nurses. So the floor next to them is the acute leukemic unit. That's been moved way down into the basement area, way down, hidden out of sight, and that whole floor is now the COVID-19 unit. They're having major struggles getting staffing for that. They are actually in on Sunday, all the mucky mucks, to try and open it for tomorrow or tonight. We need the COVID floor. Meanwhile, our stroke unit has now become our medical unit with COVID overflow. So the stroke unit got moved to the respiratory floor, and the respiratory floor got moved to a different medical floor. So we've contracted the amount of medical beds we have dramatically, but we've actually created a bunch of COVID floor beds and ICU beds. Now I think this is kind of a good idea, and the thing behind this is we can gather people together with a similar diagnosis for the time being. But obviously if we get a surge like Italy or London has had, it's going to be the entire hospital quite quickly. So we're doing what we can as a phased response, and I think that's really smart, and I think it's a great idea. Without having the patients in negative pressure, it's probably preferential if the nurse is on the actual unit in PPE the whole time. That's not yet happening. Hopefully that will change quite dramatically and soon, because it's a huge risk to be wandering around with no face mask on inside a unit with all COVID patients or all COVID potential patients and no mask on, except for when you go in the room. I think people have to get over this. We have to assume the whole of the floor is actually infected. So this is going to go on, and this is going to increase, I think, quite clearly. Everybody in administration, everybody in infection control, everybody everywhere in my place is now kind of on side where I've been for quite some time, is that we are going to get whacked. There's no question about it in the Greater Toronto area. We have got community transmission. It's going to take a miracle for it to go away. Everybody that's hoping on the 1st of April, like President Trump, that it'll get hot and it'll disappear, I think it's pretty clear from the countries that have outbreaks that it's going to have to get really, really hot in Toronto, and that won't be till June and July for it to go away. So it's not going away. One of the other things we're doing is Kitty's spending a lot of time on the phone on her days off, talking to her extended family. We have decided not to go knocking on doors and handing out our information, my phone number, to people in the local area. What we're doing is my neighbour Doug, he's actually got the envelope with the letters in it, and he's going to wait till late on Wednesday, so the virus is dead on it, there's no transmission that way from us to him, and then he's going to hand them out to people. He's also said he's quite happy to come in if we need him to quickly feed and water the dogs and cats, and that's absolutely wonderful. It's too easy for people to say, no, they might be infected, I'm not going in, and refuse to help. And I think that's the message that I was trying to make in the big video I did on helping people and setting up local networks on your own street. People will put themselves at risk, however slight, to help you out, and it's really, really important that you set networks up now to get you help in your home and for you to help people in their homes right now. Don't wait for this to be a cataclysmic sudden wham. It's just not appropriate. It's really important that people are going to help people. It's vital. And it's really important that preppers stop with the guns and the prepping and the martial law and the lockdown and FEMA camp rubbish that they're putting out there, and they actually start using their skills and their paranoia and their hoarded goods for years to actually look at ways that they can safely help people who are actually on their street, because it's going to be very, very local for quite some time. Now everybody wants to know, how long is this going to go on for? Nobody knows, right? I would say at least 6 to 8 weeks, and I would say probably 16 to 20 weeks. It could be longer, who knows? If there's a second wave, it's going to be a lot longer than that. We need to focus on the fact we are at war. This is a world war against the SARS-CoV-2 virus and this disease. It isn't a small thing. If we lose 2% of 50% of the population, that's 1% of the population will die. We know from Italy that 20 to 60-year-olds without comorbidities are highly at risk from ICU requirement and possible death. In the first phases you see the old and the sick because that's where they're finally getting the expression in the community where it requires ICU. They're much more at risk of catching the disease and much more at risk from dying of the disease. But generally speaking, the 20 to 60-year-old population without comorbidities are the population that Italy is seeing on the ventilators after the initial splurge of old and sick. We're going to try and get wills done this week, probably online. We're going to get them done. It's not because we expect to die or we want to die, because we don't, and it's not because we're heroes or any of that stuff. And I want to address that. Neither Kitty nor myself is a hero because we work in healthcare. It's our job. We could have decided to retire in January. We thought about it. I actually wanted Kitty to because she's much more at harm's risk than I am. But we decided we can't. It's come down to it, and despite what I thought after SARS 2003, I can't abandon. And I think if we had retired in January, I think we would probably return to work. It's not because we're heroes, it's probably because we're stupid. It's because I don't feel comfortable not using what I have and my skills, and I've had a pretty good life by working as a nurse and now working as an administrator, and I just can't do it. Like Kitty says, she's got a lot of young 25-year-old ICU nurses, and she's needed there. They need her experience and her calm, level-headed approach and her ability to do things outside of the box. For a long time now, modern society's been awesome, and everything's been single-use, and everything's always there, and the computers are there to type and all the rest of it. We have the paper skills, we have the nobody's in the hospital, we have to figure out our own transfers, etc., etc. So the older nurses actually have the old skills to deal with a calamity. The younger ones really don't. Now, of course, over time they'll learn really, really fast. But I think it's important that we are there. Now, people are offering protective gear to our hospital, that's great, and we are encouraging it. But unless you are a factory owner and can mass produce stuff, if you have, say, 10 or 25 N95 that you know you don't need, and you're thinking, well, I should give them to the hospital, I actually don't recommend that. There's a good chance that they'll go into stores and they may not use them because they think they might be contaminated. There's a whole bunch of issues there. If you have extra N95s and you know for a fact you're not going to need them, you must know a nurse or a dental assistant or an ambulance driver or a fireman or a police dude on your street. Drop them off outside the house with a happy note, wishing them well, okay? Give it to people. They'll probably, like if somebody gives me 25 masks, I'm going to use them. If you give 25 masks to my hospital, they may not actually ever get out there and be used because people are still in normalcy bias. We got our weekly food delivery on Friday and they're taking precautions with that, etc., etc. But it was really nice. They did give us the full order that we asked for. Well, no, we're not trying hard, but we are having to switch our entire food delivery to that service now, whereas Kitty loves going out to Nature's Emporium and buying. We can't do that anymore for three main reasons. One, we might be infected and not knowing, and we might infect other people by going out. We're at high risk. Two, they may infect us. Going shopping is a risk. And the third reason is that the food that's in the stores needs to be kept in the stores so people who are elderly or don't have fridges and freezers, because some people are poor and don't, can actually go every other day or so and get food. Because I think we are overlooking the fact that a lot of people are not as fortunate as perhaps we are. So we did get a DVD player. It arrived in 18 hours, so we left it for a while for the viruses to die on it. Just in time delivery, eh? As long as the stocks are there, it's great. So we actually now have a functional DVD player. So we actually watched Battlestar Galactica, the first episode, last night for 3 hours, and thoroughly enjoyed it. So we have a ton of DVDs. If we end up on home quarantine, we can do that, and then when we're at home we can actually watch stuff as well. Broadband is going to be difficult. Uploading to YouTube is going to be difficult. They haven't yet started to restrict the bandwidth in North America, but they will. And I think that's the thing that people need to take on board. Standard definition videos are going to be there. People need to limit their videos to actually what's important because communication is vital. And what we did on the last night going to work was actually did a video of Kitty answering questions for Harshman Hill's site, and that's really, really nice. and I'll be flipping that link over to him today, and I'll probably put it up on my own site tomorrow anyways. He's got a very, very important series going on where he talks directly to healthcare workers in various different places, or he's asking them questions online and then he says what they said. It's really important to hear what the voices are saying here. There's a lot of people out there who still think this is a hoax, or it's just the flu, or it's not a big deal. There's a Canadian who built a bus who's actually driven down south to America and has actually put up a film yesterday of himself lounging on the beach. I'll be unsubbing him. People that are trying to kill Kitty by stupidity, I have really done it. I can't deal with this anymore. It's just infuriating. And it's the people in England who are going to the stores and just mass buying because they don't care about anybody, and they're probably trying to resell most of that stuff. So they're stopping the ICU nurses and the emerge nurses who are working 12 to 48 hour shifts right now in England, trying to stop people from dying from buying food after shifts. It's disgraceful. And it's also disgraceful that the government and the food companies aren't delivering food to those workers in their own homes. It's terrible. You know, people have got to get a grip here. We're at war. You can't have the healthcare workers and the grocery store workers and everybody else, the transit workers, dependent on just making do like everybody else is trying to do. Those people need to get access to fresh food, they need good quality food, and they need to be getting adequate rest, because you can't have the frontline staff go down. If we do go down in the first surge that we're going to get in Toronto, there's going to be a lot more people dying. It's as simple as that. The skills of respiratory therapy and the respiratory therapists that we have are excellent. The skills of the ICU nurses, the skills of the emerge nurses are absolutely amazing. There's not that many people who can do that. The training is huge and it's long. It's very complex in the modern world. It needs to be done, and it needs to be done by the community. Those people need to be supported 100%. So that's it for me. Just a quick update on Sunday, March 22nd. Hope everybody's doing well. Hope everybody's keeping cheerful. I'm feeling fairly depressed on and off. So is Kitty. We've got a huge sense of fatalism about this. It's fatal for a very few people. What are you going to do? You have to do the work, and you have to do it. And we're trying to do what we can do. And you know, our precautions are not perfect. And you know, it's great saying, you know, wear raincoats and all of that stuff, but it's impractical, and it also sends a wrong message to our teams, because people are close to hysteria right now in the hospital system. The longer it takes for this to break out here, the worse that hysteria and fear is getting. We are having serious problems with intensive care beds right now in Toronto, at least in my part of Toronto, but floor beds, we've got plenty of them, and that's a really worrisome thing. China gave us a really wrong impression about this disease. Italy's pretty much showing, and London's pretty much showing, that the vast majority of patients who come through the ED with COVID-19 disease require ventilation. Not the minority, not 5% or 20% of the people who are sick with it to be hospitalised. It's looking like more like 60 to 80 to 90%. And that's going to be an incredibly difficult thing to deal with. So remember, in SHTF, tomorrow will always be worse than today unless you prep. And in a pandemic, tomorrow will always be worse than today, even if you do prep, but maybe not quite as worse. Toodles. This has been a 2020 Bad Terrier production.